Welcome to Conversations with Caregivers. My name is Christopher White. I'm one of the clinical social workers here with the Dementia Care Collaborative and Dementia Caregiver Support Program here at Massachusetts General Hospital. Some logistics to begin with. You might notice that, upon entry, you are muted. We would ask that you stay muted throughout the entirety. This session is recorded, so there is a chat function down below which we'll be using for Q&A. We would ask that you not put any personal information down there because that can be seen by the entire group. Again, the chat function will be used for our Q&A. So if you have any questions or comments that you'd like to share and have be part of the Q&A section, please type them down below and we will include them when we can. So with that being said, welcome. Again, this is the Dementia Care Collaborative, part of the Mass General Hospital Division of Palliative Care and Geriatric Medicine. We were launched in 2017 with the goal of nothing less than the transformation of memory care in the medical system, and particularly here at Mass General Hospital. In addition to the research conducted here in the division to improve dementia care, the Caregiver Support Program exists specifically to educate and support patients, caregivers, clinicians, and the community at large. We have a variety of programs to choose from, including this one, Conversations with Caregivers, but we also have health and resiliency courses that are offered a few times a month, as well as practical skills for dementia caregivers and support groups that are always ongoing and facilitated by my social work colleague, Barbara Moskowitz. Our program is largely funded through philanthropic support, so if you're interested in learning how to support our program and all the work that we do, we would ask that you please visit our website at www.dementiacarecollaborative.org. We can put a link in the chat function right there. Email or speak to any one of our team members. I happen to be the only team member here tonight, so if you have any questions, please feel free to message me. And with that being said, I take great pleasure in introducing our speaker for tonight, Dr. Stephen Arnold. Dr. Arnold is the E. Gerald Corrigan, PhD, Endowed Chair in Alzheimer's Therapeutics and the Translational Neurology Head and Managing Director, Interdisciplinary Brain Center at Massachusetts General Hospital. Dr. Arnold has conducted long-standing research on neurodegenerative disease pathology, molecular biomarkers, and therapeutics for cognitive decline and psychiatric syndromes in late life, and has led broad clinical and translational research programs. He has authored over 250 scientific articles, reviews, and chapters. His current scientific interests include biomarkers in brain aging and dementias, metabolic factors driving dementia, and protective factors that account for cognitive resilience, all with the goal of accelerating therapeutics, discovery, and development. And so with that being said, I turn it over to Dr. Arnold. Dr. Arnold, welcome, and very happy to have you with us tonight.
Hey, thank you, Chris. Can everyone hear me okay, Chris?
I believe so, yes.
All right, and let me share my screen and put it on presenter mode. So I'm really delighted to be here with everyone and to share some of the most exciting things that I guess I'd have to say that I've experienced in my career with Alzheimer's disease over the last 30 years or so. As Chris mentioned my titles and things like that, I'm a neurologist. I'm also a psychiatrist, and I do see patients over at the Memory Disorders Unit here at Mass General. And I run a research program where we run clinical treatment trials for Alzheimer's disease, as well as a laboratory for blood tests and spinal fluid tests for Alzheimer's disease and other conditions of aging. So what I'd like to do is kind of give you a broad overview at first of, the way I see the field of aging, cognition, and Alzheimer's disease. I think many of you are already quite familiar with some of the terminology that we use when talking about dementia and mild cognitive impairment, but I'll just, refresh everyone with how I define and understand these things. And then I'm going to talk about really the two major new advances, huge advances, I think, in the care the evaluation and management of people with Alzheimer's disease. So let's see here. So just to remind ourselves, I often start my talks with this type of um, graph, if you will. Often I actually just talk about how we all have changes over the course of our lifespan, especially in late life. I usually ask the audience when they think some of the memory difficulties occur that we all experience as we get into our 60s, 50s, 70s, and the like. And some people say, oh, when I hit menopause. Other people say, 50s. And then I pull out this slide, which really shows that we peak in terms of our cognitive abilities at around age 20, and it's kind of downhill from there. And people are often surprised at that. But what we're really describing is happening within a relatively narrow range. So we all have problems where you walk into a room, you can't remember, why you walked in. We all have more of that tip of the tongue phenomena where you just can't remember someone's name or the name of an object. Our ability to multitask often kind of decreases as we get older. We all have these experiences, and they do become more prominent as we get older. But really what we're talking about here is when people fall off these curves. And when people have a noticeable, clearly it's different degree of cognitive difficulties, that is beyond what you would expect for normal aging in our peer groups and all. When we do have more of that cognitive difficulty, but we're still able to get our day-to-day chores done, and we can go and shop, and we can drive and things like that. It may take us longer to do things, but we're doing it. We call that mild cognitive impairment, or MCI. And for some people, that's just the way their brain ages. And they just kind of stay in a mild cognitive impairment, and things take longer, but they're managing. Other people, mild cognitive impairment could be the first, stage of something more serious and progressive. And when we have cognitive difficulties that start to cut into our ability to function independently, that's when we use the term dementia. So that is when our memory difficulties or language or our executive functioning, our ability to make decisions and process information, when that declines to a point that we have trouble figuring out how to pay the bills or shop in a store, that's when we use this term dementia. Now, there are many, many causes of cognitive decline as we get older. And that's why I always emphasize to people that it's very important that if you are having some noteworthy cognitive difficulties, that you at least see your primary care physician. Because as you may be able to make out, maybe not grade out in the background of this pie chart, are a whole long list of things like thyroid disease, vitamin deficiencies, sometimes some cerebrovascular disease, different inflammatory conditions. All of these things are things that can affect our mental functioning and are identifiable and often quite treatable. But, when someone does have a problem and they get these things checked out and still we can't really see what's going on clinically with someone, then we're dealing with something that is likely a disease of the brain. And of all the causes of mild cognitive impairment and dementia, Alzheimer's disease is by far the most common. It really accounts for, maybe 60 to 70% of all causes of MCI, mild cognitive impairment and dementia. Maybe 20 to 30% are due to mini strokes or small blood vessel disease of the brain, and very, very commonly, vascular causes are mixed with Alzheimer's disease. So we often call that mixed dementia or mixed Alzheimer's disease with vascular disease. And then maybe 5 to 10% of people can have what we call Lewy body diseases. These are things like related to Parkinson's disease. So there's Parkinson's disease, and there's this condition that, in my mind, can be indistinguishable, something called dementia with Lewy body disease. And then maybe 5% of the time in people over the age of 60, over their 60s, people can have frontotemporal dementia, or also called frontotemporal lobar degeneration. These are the major diseases or the degenerative diseases that affect the brain in 30%, 40%, depends how old you are, of older adults as we get older. There are also a long list of other rarer conditions, but these are really the major players that we're talking about. And of these different conditions, Alzheimer's disease still is the most common. So what is Alzheimer's disease? So this is a picture of Alois Alzheimer, and the very first patient that is recognized as having, or based that really Alois Alzheimer actually evaluated this woman when she was living. She actually had an early onset form of dementia. And then when she died, he looked at her brain tissue under a microscope with some of the new stains that the German pathologists were using for looking at tissue. And he saw these things that we call plaques, these little nests or webs of fibers. And we call those plaques. And then he also saw these cells that stained black with this silver stain, something called tangles. And over here are actually some of the pictures of things that he actually drew of what he was looking at under the microscope. Now, well over 100 years later, we understand a lot about what causes these plaques and these tangles. The plaques, this is a very complicated slide, but I'll just hit some of the highlights of it. We know that these plaques are primarily made of a protein called amyloid or amyloid beta. And this is a normal protein that we all have, we all make in our brains, we have it throughout our entire lives. But for some reason, the protein gets clipped or processed in such a way that the little fragments of the amyloid protein that are clipped off crumple up, and they actually stick to one another, and they aggregate into these plaques here. And the plaques in the brain, made of this fibrillar aggregated amyloid protein, that elicits an inflammation in the brain as well, because the inflammation is trying to get rid of the bad amyloid protein. But in the process of getting rid of the bad protein, it's also causing damage to the surrounding tissue. So the inflammation is a major player here. So that's the plaques that are made of this amyloid. And this is going to be very important as I move on in the talk, because this is the basis for the huge news in the huge advance in treatment that we're now undergoing in the field. The other thing, remember I said there were plaques, there are also these tangles, and these are actually brain cells that have another protein in them called tau, and that tau protein also is a normal protein that we all have, but again, in Alzheimer's disease, the protein crumples up and it folds into these indigestible kind of gunk within the brain cells, disrupts the internal machinery of the cells, and ultimately the cells die. And so between the plaques and the inflammation and the tangles and the brain cells, we get degeneration of the brain. And so this is actually a picture of a healthy looking brain, and the brain is actually shrinking as cells die in Alzheimer's disease, and it can shrink quite considerably. So that's a detailed explanation, probably a little too detailed for us. But, what I'm kind of highlighting that we define Alzheimer's disease by the presence of amyloid and tau. And it used to be that I would say, and to other doctors would say, the only way you can be 100% sure that you have Alzheimer's disease is if we look at your brain tissue under a microscope after you die. But over the last 10 to 20 years, we now have a number of tools where we can actually see these plaques, these tangles, and the degeneration, the brain degeneration that's occurring in living people. And so we have MRI scans that, I'm sorry about that. Let's see. Here we go. My computer's acting a little crazy. We have MRI scans where you can actually measure the memory areas of the brain to see if they've shrunken down with Alzheimer's disease. We have PET scans, positron emission tomography, which are, used in a variety of conditions, a lot of times for cancer diagnosis, but there are certain types of PET scans where you can actually visualize the amyloid or the tau in the brain, or you can visualize how much glucose, the energy of the brain is burning. We have spinal fluid, and the other major advance that I'll be talking about today is blood tests, where we can actually measure these amyloid and the tau. So let's just take a look. Let me explain what amyloid imaging looks like. So this is a PET scanner. This is a person lying in a PET scanner. And what amyloid imaging does, as you can see here, this is a picture of someone's brain that's filled with amyloid, this red and yellow stuff, compared to a normal person. And the way these amyloid PET scans work is that you inject a little bit of a tracer that emits some radioactivity, an anti-amyloid tracer. And the tracer circulates through the body, and wherever it meets amyloid in the brain as it's circulating, it binds to the amyloid for a little bit, and it emits these radio particles that get picked up by the scanner. And then it all washes out of the brain, and it's a very low dose of radiation. It's like comparable to a chest X-ray. But with that, we can remarkably see the amyloid that's present in the brain. And again, I'll emphasize the importance of this because it is what, is really allowing us to measure whether any of the new medicines that are coming out lower the amount of amyloid in the brain, lower the amount of Alzheimer's disease in the brain. Another test that in my work, I do an awful lot of spinal fluid testing because you learn so much about the health of the brain in spinal fluid, through, a procedure that's not a whole lot more involved than a blood test. But, it does have a certain stigma about it. But basically by taking a sample of a couple teaspoons of the fluid that just pools down at the bottom of the back with a needle, this actually is what the spinal fluid looks like. It's clear. It's like a clear liquid that goes up and down the spine and bathes the brain. And in spinal fluid, we can actually measure not only the amyloid and the tau, but we can measure inflammation, how much inflammation there might be. We can measure other metabolites that can tell us a lot about the health of the brain. And this actually are two of the research technologists in my lab next to a big sort of robotic machine that we use where we can actually measure the amount of tau and the amount of amyloid, and we can compare people who have Alzheimer's disease and who don't have Alzheimer's disease, who have other conditions that may be causing memory decline, and we can actually do these tests on spinal fluid to determine whether someone has these proteins that define Alzheimer's disease or not. But the biggest news in the last year or two really is that we actually now have blood tests for Alzheimer's disease. These are not quite approved yet for widespread use, but they are looking incredibly promising, and we can measure the amount of tau and amyloid in the blood to determine whether, someone has evidence of Alzheimer's disease in their brain. So, this actually shows what some of the, the big machine that we use to measure this. This is a picture of blood. These are some techs that are kind of working on these little plates in the lab that we measure. And this is one of the types of tau that we measure. And it shows the difference between people with normal memory and thinking and people with Alzheimer's disease. There's a difference. The field is, and it's good, in this test, in a blood test, we can be accurate as to whether someone has Alzheimer's disease about between 86 and 90% of the time. That still means we're going to miss some people with Alzheimer's disease, and we're going to call someone with Alzheimer's disease even though they don't have it, because there is some error in this assay. So we think of this as kind of a screening test in a way. Like, you might get, like men might get a PSA test for prostate cancer. We know there are a lot of people with high PSAs that don't have prostate cancer, and there are a lot of people without, with low PSAs who do have prostate cancer, but it's a screening test. And so that's how we've been thinking about the blood tests for Alzheimer's disease. However, the science is rapidly evolving. And this is actually some new data coming from my lab where we used a different kind of tau reagent in the blood tests. And, we'll see how this holds up, but we're getting about 98% accuracy at at determining whether someone has Alzheimer's disease in their brain or not, when we compare it to either amyloid imaging or spinal fluid tests, which are like the gold standard. So this is a major, major advance where we don't, where again, I still think this will be, you'll want to confirm this, but, but this blood test for Alzheimer's disease is a real game changer in the field. And what we have learned from all of these different biomarkers of disease is that the changes in the brain that are occurring with Alzheimer's disease are happening years, if not a couple of decades, before someone notices that their memory isn't as sharp as it used to be. No one wakes up one morning with Alzheimer's disease. This is a slow process that has been kind of happening over time. Just isn't like, I don't know how good this analogy is or metaphor, but like in heart failure, due to atherosclerosis, it's not like you woke up with cholesterol in your arteries. It's something that's been building for a while that slowly starts to decrease the blood that's getting to the heart, and the heart starts to fail. At least one cause of heart failure. And so the biomarkers, can tell us whether Alzheimer's is developing in the brain. And if it is, it helps us predict what someone's future holds. Now, this was fine, but, to some degree you could say, well, if there's nothing that I can do about it, if there's no real treatment to get rid of the amyloid or the tau in my brain, then do I really want to know? Or, yeah, maybe I want to know and I'll plan my life accordingly. But how much, and that is useful. But we want more, obviously. But, until recently, this is what we had to offer. We had our Aricept and our Exelon and our Reminil and our Namenda, and these, as I always would tell my patients, may provide a little bit of benefit for some people. That's my ringing endorsement of how good these medicines were, but they really didn't change, they didn't change the course of the disease. They may have helped some people a little bit. But now, as I'm sure most of you have been, are aware of, there are these new anti-amyloid immunotherapies that do seem to reduce pathology in the brain. So we're going to talk about that a little bit, and I want you to kind of jot down your questions, because I really want to try to have some conversation to answer all the questions about this. Biogen came out with their aducanumab. Eisai with Biogen came out with lecanemab. We are anticipating that lecanemab will have full FDA approval in a few weeks. Donanemab is another one by Eli Lilly. I think that also, the data are looking very good, very strong, and I think that also will, will gain approval. Don't know. And so let me tell you what these new immune therapies do. So I showed you about how amyloid is secreted and it clumps up into these plaques. And what this lecanemab or Leqembi does, this is the Eisai drug, is that you get this medicine through an IV every 2 weeks or every month. And this drug actually binds just to the clumped up amyloid in the brain, and basically pulls it out of the brain. So you're absorbing and metabolizing, basically getting rid of this aggregated protein that has accumulated in the brain that is causing the damage that people are experiencing with Alzheimer's disease in the brain. And I showed you some pictures of the PET scan of someone with a normal brain and the amyloid brain, and we can kind of plot this out. This was the data from the lecanemab, the big lecanemab study, showing the amount of amyloid in the brain in people who received the placebo over 18 months compared to the amount of amyloid in the brain in the people who received the active medicine over 18 months. And you can see a dramatic decrease in the amount of amyloid as measured by the PET scan, to the point that some people actually looked normal again in terms of the amount of amyloid. I'm talking about amyloid here. So you're reducing the amount of amyloid dramatically in the brain with this medicine. So this is the graph that I just showed you, showing the huge difference. And then what we see is that there was a significant slowing down of the progression of the dementia. Because it's one thing to say you're getting rid of the amyloid, the brain, but it's another thing to say, is my life getting any better? Or is my life any, and my dementia, my memory impairment, is it any better taking this medicine than it would be if I were not taking the medicine? And so there was a highly significant difference between the active medicine group and the placebo group. So this is the first time in my career that I've seen a clinically relevant improvement or difference with a drug that has been attacking amyloid or tau. Now, it's modest, okay? It's convincing, but it's modest. No one got better from their dementia. What we see is that on average, and this is where I have a lot of problems with the way that these kind of clinical trials are reported, but you have maybe about a 30% slowing of the progression. The dementia is still getting worse, but just significantly slower than it would have been. So I view this as a game changer, because it's actually you are actually changing the disease and seeing an improvement in someone's clinical situation. This is not a home run. This is a base hit. But it does suggest to me that we've made an important advance in attacking Alzheimer's disease. Now, there are a lot of concerns and controversies that we can talk about with this. There are risks and side effects with all of these 3 anti-amyloid immunotherapies. About 20 to 30% of people can have, on their MRI scan, you can see some swelling. You can see some micro hemorrhages, some tiny little bleeds. Most of these are not symptomatic, but some can be. And some, there have even been a couple of deaths in people that are attributed to these immunotherapies who may have had a major, not a micro hemorrhage, but a major hemorrhage. Another controversy is, okay, yes, it works. It seems to slow down Alzheimer's disease, but how much? And is that difference really worth it? We can argue, and I hope we do argue about that. I argue with myself about that. The burden going in you have to get these through an intravenous. You're talking about 12 months, 18 months going into an infusion center every 2 weeks or maybe every 4 weeks. Is that worth it for the clinical benefit that it provides? I think, as I said, these treatments is really the first step. And the company, we've proven the concept. Now what the companies will probably do is say, okay, do we really have to give it? Can we develop a form of the medicine that people can just, inject in their skin, every 2 weeks at home, kind of like someone would give themselves insulin or some other subcutaneous medicine. That, I think, is what we're looking at over the next year or two. There's controversy over the cost. The medicine itself will probably cost around $26,000 per year, but that doesn't include the infusion services, the MRI scans that you have to use for monitoring, whether the medicine's safe or not. And then there are significant issues, and it's not clear yet whether Medicare will pick up the tab or not on this. The VA has said that they would. I don't know what restrictions they have on it, but Medicare hasn't yet said that whether they would or not. And that, of course, is going to impact the availability and the access, especially for underserved groups that typically have less access to healthcare. So, so that's really the, this is just a picture of what some of those severe brain swelling, some of the side effects on the MRI scan can look like, or these tiny little black spots here. But as I said, these are serious effects like this are really quite rare. And there are some ways to predict who would be most at risk for those, or not. So, I think those are all the slides that I have. I think this is just a few actually before COVID, some of the people in my group were now about twice this size for our clinical trials program. And I'll stop my sharing now. So I think that, the two kind of, I really do feel that these are game changers. The two major advances that are clinically relevant, not just in terms of our scientific understanding, but actually things that can make a difference in people's lives. The fact that we now are so much better at diagnosing whether there is Alzheimer's disease in a person. Now even with a blood test, and then the fact that we now have some medicines that have shown that you can modify the disease and improve clinical, clinical progression. Now, one other comment I just want to make, these studies with the immunotherapies were done in people with mild cognitive impairment due to Alzheimer's disease, where they had biomarker-proven Alzheimer's disease or very early stages of dementia. The disease is already kind of taken hold. You're getting rid of the amyloid. You may be getting rid of some of the tau, but if the inflammation is already going, if some of the metabolic disturbances are already going, many of us think that that Alzheimer's disease, like, the way cancer is treated now so effectively, it's going to require combination therapy. You're going to have to identify what is wrong in the brain and tailor it, because what my Alzheimer's disease is going to be a little bit different than your Alzheimer's disease. And the treatment or a combination of medicines that are going to be treating my Alzheimer's disease may be different than yours. The other thing that we are trying to, or that we think is going on is that, but these studies are so hard to do, is that what if we can identify someone getting amyloid developed in their brain before they have mild cognitive impairment, before memory? Can we actually prevent Alzheimer's disease and clinical Alzheimer's disease? We think that if we can get rid of the amyloid early on, that we are going to be able to prevent it, but we haven't proven that yet. Those studies are they're long, they're expensive, they're hard to do, but I think that that's what many of us, feel the future is holding. So let me stop at that and turn it over to, I guess, Chris. I hope there are some questions coming in, because I hate Zoom. I much prefer just kind of conversation with people.
Yeah, we certainly have a couple of questions already in the chat. I would say, keep them coming. I'll just sort of get through them in the order that they appeared in. So with that being said, let me see here. Okay, so the first question from Virginia State, and she asked, do any of these new drugs work for frontotemporal dementia?
So these drugs are targeting amyloid very specifically. And amyloid is the sine qua non. It's the defining protein abnormality of Alzheimer's disease, and Alzheimer's disease only. Frontotemporal dementia is a dementia that, so it's actually, some types of frontotemporal dementia, some frontal dementia is caused by Alzheimer's disease, but most of the time it's caused by other protein abnormalities. So, we talk about tau frontotemporal dementia or TDP-43 frontotemporal dementia. When we talk about frontotemporal dementia, we're mostly talking about those other forms, not the Alzheimer variant that can cause frontotemporal dementia. So it's actually, and if I can just sort of expand on this a little bit more. So anyway, no, an anti-amyloid therapy will not work in someone unless they have amyloid in their brain. And that's why, getting a biomarker to see whether they have amyloid in their brain is critical. We would not want to treat someone with dementia who we don't have confidence that there's actually amyloid that's there, because there's lots of side effects. It's expensive. It's hassle, and you don't want to give a medicine unless you don't give penicillin to someone with a virus. If you want to make sure that they have a bacteria that will treat that penicillin will treat. Now,
So-
okay, go ahead.
No, I was just going to remark. I mean, it certainly seems like early detection is really the key to sort of determine which of these therapies is going to be the most effective for sure.
Yeah, yeah. Um, Let me just, if I can, Chris, let me talk about some of these other dementias for a little bit, because
Yeah.
there's something common about all the major degenerative conditions of aging. So I mentioned Alzheimer's disease is a slowly progressive degenerative condition, and it's caused by this crumpling up of the amyloid protein and the tau protein. Okay. Parkinson's disease. This is another disease where it's a different protein. It's a protein called synuclein or alpha synuclein, but it also crumples up in the brain cells that make that protein to cause the degeneration. So Parkinson's disease, dementia with Lewy bodies, something called multiple system atrophy. These are other diseases that can cause dementia where it's a different protein, but the same kind of process. The protein gets crumpled up and then it can't be cleared by the brain. Frontotemporal dementia. I mentioned that protein called TDP43, and then there's different kinds of a different kind of tau protein that's also abnormal. Same thing, normal protein somehow crumples up, causes brain cells to die, people develop dementia. So some of us are looking at this commonality among these different kinds of dementia and saying, can we prevent that protein, any protein, from misfolding? Or if it does misfold, can we clear it out of the brain? Can we help the brain get rid of the waste that's accumulating? It's almost like trash that's accumulating in the cells that ultimately will kill the cell. Can we enhance the waste removal of proteins that get crumpled up? All right, I'll stop.
No, great, thank you. We're getting a lot of questions hot and heavy. So moving on. All right. So the next question is, does an MRI or a scan for other tissues show the tau and plaque, or do you have to get a specific test for those?
Well, so there's MRI and then there's the PET scan. So the MRI is especially good for looking to see if the brain has degenerated, if some of like the memory areas have shrunken down, but it doesn't tell you what the protein is or what the molecule is that's driving it. Or MRIs can show whether there have been mini strokes or small blood vessel disease. That can be important, but it doesn't show whether there's an amyloid abnormality or tau abnormality. For that, you need molecular imaging. You need to look at these protein molecules, and that is what the PET scanning can do, or the spinal fluid. So MRI is good. It gives you a lot of information, but it's not good enough when you need to know what molecule or what protein is actually abnormal.
Great. I'm just kind of going through. I'm seeing a lot of questions relating to it. Have there been any advancements in our ability to predict the rate of progression when it comes to Alzheimer's disease? I think a lot of people, one of the things that I think can be very frustrating is the unpredictability of what's going to happen and when. Have there been any advancements in that area?
So yes, but not nearly enough. And it's a critical, I'll just say that we are the Massachusetts Alzheimer Disease Research Center, our National Institute on Aging supported research center, just sent in a renewal application for 5 years of funding. The central question, that the way we lead it off, is that the central question that we are trying to answer with our next 5 years of funding is, what will happen to me? And that is, determine what is the progression. If you come to a doctor, how can we tell you what will happen to you? And we can say on average, people with Alzheimer's disease progress at a certain rate, and after 6 years or 8 years, 80% of people have, need help with everything that they do. But we've all seen many people who 2 years later need a lot of help with everything. And we've seen other people that 20 years later are still functioning and going on vacations with their family, having had Alzheimer's disease for 20 years. And we don't yet have the tools that can allow us to predict. This is actually a big focus of mine in my research, which is really to kind of understand individual differences. Why is it that someone will progress fast as opposed to someone who will progress slowly? How can we use biomarkers, blood tests, spinal fluid tests to predict what my Alzheimer's disease is going to do compared to what your Alzheimer's disease is going to do?
And that actually leads into a similar question, or at least one that sort of builds off of that. After a diagnosis, are there any factors that, can generally predict or impact the pace of progression?
Yeah, I mean, there are some features, one of the things that we're looking at now is the amount, like say in spinal fluid or in blood, the amount of abnormal tau that we can measure. And, we think that if you have more tau in your blood, then you have a higher rate of progression. So, there may be some biomarkers that we think are going to help. It's also important to look at some of the other, lifestyle factors that also are important for determining progression. So I'll give one example. A woman a nurse actually, who participated in our research study with an anti-tau trial. She was in one of our clinical trials. She was a maniac. She was in her late 50s. She was a maniac about exercising, eating well. She'd go to the gym 2 or 3 times a day. And she did everything that we recommend people do, in terms of diet, exercise, stress management. She was incredibly proactive. And she was in our clinical trial. And she, for 5 years, did not budge in terms of her memory and thinking. And I don't know whether it was the medicine that she was on in our clinical trial or the fact that she had such a healthy lifestyle that she used. I tend to think that it was the lifestyle, because the medicine didn't work so well for most any other person.
Awesome. Yeah. I mean, in our work, I generally emphasize the importance of healthy lifestyle, and, modifiable lifestyle choices as being, what we call protective factors, and, to the greatest degree that they can be. So absolutely. The next one is, are the blood tests available at MGH? And if so, how do I schedule a test?
Okay. So as I said, the blood tests are still, so the blood tests are still considered in research phase. So the big it's still going to be a year or two before you can go to LabCorp or Quest or Mass General to get a clinical blood test for Alzheimer's disease, but it's rapidly happening. There is one company called C2N that does offer a blood test, but it's very expensive. It's like $800, and I'm not sure whether it's covered by insurance or not. We don't use it. I don't know if I've ever used it yet.
If people were interested in that type of test, is there anything that would concern you about the efficacy of getting that sort of test, or what's the difference
Well,
between?
so it's the same kind of it's the same issue. That test that's currently offered has about 93% accuracy, which means that 7% is wrong. Which means before you make the say you're positive for that blood test, you're still going to want to get it confirmed with a spinal fluid test or a amyloid imaging or some other biomarker. And this is why these blood tests aren't yet widely available, is because we're still working out the details. It's like, as I mentioned, like the prostate, prostate test for men, prostate cancer test for men. No one's going to get a PSA blood test and then go into radiation treatment for prostate cancer. If the test is positive, you'll get a biopsy, or you'll go to the urologist and find out. And I think that's where we're at. You want to confirm before you begin any kind of treatment as such, or make any decisions. You want to get it confirmed.
Yeah, and it sounds like that involves multiple tests that if they all say the same thing, then it's likely to be more accurate.
Right.
All right. So, okay. So the next two questions are kind of related. I'm just going to read Karen's, and I'll come back to yours, Julie. Karen asks, I have read a lot about mitochondria cells and how we take care of ourselves with good food, minimal stress, exercise, good sleep, etc. Can we do things in our lives now to impact brain mitochondria to improve brain function and disease resistance?
Well, I would say that this also is an area of interest for us, and we're trying different nutritional supplements and nutraceuticals to see whether they can enhance mitochondrial function. So for people that don't know, mitochondria are parts of the brain cells and all cells that basically produce the energy of the cell. And there can be a problem in Alzheimer's disease and the other dementias, or these sort of power plants of the cell. So the things that we do know impact mitochondrial functioning are, good nutrition, restful sleep, stress everyone has stress. How we manage it is what's important. Exercise, aerobic conditioning, these are things that provide the oxygen to the mitochondria to function. So those are the most important things to do. Whether any of these new nutritional supplements, these vitamin B derivatives, and, we're looking at pomegranate extract and things like that are supposed to be, mitochondrial boosters, they may work. They work great in mice. They work great in, but I've got, hundreds of Alzheimer's cures that work great in mice with Alzheimer's disease already. Do they work in humans? We have to do the work. We have to do the research to know. And, and you can go to your GNC or your Whole Foods and see a wall of these kind of mitochondrial enhancers for boosting your energy and your sex drive and your improving your sleep. Some of them may work. we just don't know because the research hasn't been done.
And that relates to the other question from Julie. Are there any specific foods or supplements, given that you just mentioned that, to help reduce amyloid in a person diagnosed with early onset Alzheimer's?
So again, this is where I just don't know. Um, there are, we have these mouse models where we have these mice that we manipulated their genes so that they get amyloid plaques and tau tangles. And we can change their diet. We can give them pomegranate extracts and blueberries and things like that. And it does work in these mice. It can reduce the accumulation of amyloid. It can improve their behavior. Whether it'll work in people or not, I just don't know. Lately I've been thinking, that a lot of these nutritional things that we know are, that we've heard are so good for us. I think that it's something that you have to practice for a long period of time in order to have an effect before the disease. If you're 72 or 76 and you're developing Alzheimer's disease, all of a sudden eating a quart of blueberries a day is not going to do it. It may help a little bit, but it's not going to do it.
Blueberries are fantastic, by the way. I can't recommend them enough. All right. The next question is Alzheimer's genetic? Or is there a genetic component to Alzheimer's?
Yeah. So most Alzheimer's disease we call sporadic, meaning that, so there's genetics and then there's genetics. And what I mean by that is that there are, that there are about 2 to 3% of all Alzheimer's disease in the world is due to a mutation in a particular gene that affects amyloid processing. Okay. But in those are early onset Alzheimer's disease. They affect people in their early 50s. You see it in every generation. If you have it, your mother had it and your grandmother had it, and it breeds true through the generations. That's rare, that someone would have a hard mutation in one of those genes. Most of us, it's kind of like, then there's ApoE, apolipoprotein E, that I think many of you have probably heard. And this is a risk factor. So if you have apolipoprotein E, a certain type of gene, type 4, then, if you inherited one copy of that gene from your mother and you didn't not from your father, then your risk of developing Alzheimer's disease, instead of, having a 20% chance over your lifetime, you may have a 35% chance over your lifetime. If you happen to be unfortunate and inherit one of these risk factors from each of your parents, then your chances are about tenfold higher but still, I have seen many people in their 90s with perfectly normal memory and thinking who have 2 copies of this E4 gene. So it is a risk factor, but it is a risk factor, but it's just a risk factor.
It's not a guarantee.
Not a guarantee.
One question I have just on that, I know we talked about the impact that lifestyle can have, on disease progression and just quality of life. I'm wondering, in terms of development or, this mutation in the genetic profile, have there been any studies that are looking into the environmental impact, something like pollution or, things in our environment that may impact whether or not somebody's at higher risk of, developing any type of dementia?
Yeah, so that's actually, it's very interesting. And now with people have heard the term genomics or proteomics or metabolomics. Now there's a different kind of omics called exposomics, what you're exposed to over the course of your life and how that impacts you. And there's some very interesting data. If you live within, a block or two of a major highway, your risk of developing Alzheimer's disease is significantly higher, a little bit, but it's significant, statistically significant. You know, I actually think that whether it's causing Alzheimer's disease per se, meaning amyloid plaques and tangles, or whether it's just causing a wear and tear effect on the brain, stress and things that induce stress are significant risk factors for developing dementia later on. And I think it has, whether we're talking about emotional stress, physical stressors, post-traumatic stressors, these things do increase our risk for it. And I think it's because of the wear and tear effect it has on the brain and the brain connections. So I think that that's important. In diseases like Parkinson's disease, there are some specific things like insecticides that are used in farm. Farmers have a higher rate of developing Parkinson's disease than non-farmers, and it's been attributed to some of the insecticides and pesticides that they use. So this has been also a very hard area of research to gain traction in. But now with, machine learning and artificial intelligence and huge big data, we're beginning to sort through some of the things in the environment that can lead to increased risk for dementia.
Thank you. All right. I'm seeing a couple questions, and I'll try to summarize them. Josh Merrow asks, I've read that lecanemab is significantly less effective on women than men, and that it is less effective on younger patients than older. Any insights on this?
I noticed that too in the published, and no, I don't have any insights. I don't know. It's very important. My eye went to those charts in the lecanemab in the New England Journal of Medicine article too. I noticed that. And I don't have a good explanation for it. I don't really know. Let me just say, we'll as more than a couple of thousand people are treated, as we get into the thousands or tens of thousands of people that are treated, we'll be able to sort that out. I don't have an explanation.
Yeah. I guess a sort of associated question from non-lecanemab, are there gender differences in how Alzheimer's presents or is treated? Or are there any differences from gender to gender?
Yeah, so there are sex differences. Women, we're never sure for a while. Women have a higher rate of Alzheimer's disease than men. And we always thought it was just because women lived longer than men that they, got into the ages where, Alzheimer's becomes more and more common, because the older we get, the more likely we are to develop Alzheimer's disease. Turns out that if you do control for, age, that age difference, that longevity issue is an important issue. But even if you control for that, if you factor that aging out difference between men and women, women are still at a little bit higher rate than men. And there's been a lot of work on whether it has to do with, the beneficial effects of estrogen and going through menopause, so that you don't have the estrogen that's helping with the brain connections as it does typically. There are a lot of I think that a lot of people still are focusing in on the estrogen effect. I think that's important.
Gotcha. Thank you. Let's see here. Wendy asks, I read that it is common to find in a person who has dementia after they died, and on autopsy, their brain, the tests show that they had multiple types of dementia. So these drugs that get rid of the plaque and tau, but may not help with other type of dementia. Is there anything being worked on to understand, I guess, what is going on with the ones not associated with tau or,
Yeah, so
yeah,
that's a fantastic question, and could actually be the reason why you see an improvement in that anti-amyloid therapy, but not a stopping of the disease. Even though you clear the amyloid out, other things are going on. I was actually involved for many years, and still am to some degree, with some of the big studies, the religious orders study and the memory and aging project. These were several large studies of a few thousand people actually nationally, all of whom were agreed to annual evaluations as they got older. 1,200, 1,400 nuns, priests, and brothers who all agreed to get neuropsych testing every year, and all agreed to donate their brains when they died. And so some of them developed Alzheimer's, some of them Parkinson's, some of them lived to 105 normal. And looking at that brain tissue, this was part of my research for a number of years. Most people do have mixed dementia, meaning that, again, Alzheimer's disease is the predominant cause, but most everyone has either a little bit of vascular disease in their brain, mini strokes, micro strokes, or they also have some Lewy bodies so there's a little bit of Parkinson's disease. 30% of people with Alzheimer's disease have TDP-43. That's that protein that I mentioned for frontotemporal dementia. And actually, it's interesting that people who have TDP-43 plus the Alzheimer's disease, or Alzheimer's disease plus the TDP-43, do have a faster rate of progression and decline than people that don't. So these things are additive, and they are common. Little bits are common. And some of them may actually be synergistic in terms of the progression of the dementia. It's a really good point and a fascinating point, and a really important point, because it does show the imperative that when someone comes to us for dementia and we want to treat them effectively, we need to understand the whole brain, not just whether they have amyloid or not.
Yeah, it sounds like there's a lot of things that need to be evaluated before treatment happens, and that is completely understandable. Ava Jean, I'm going to try to understand this question as best I can. Ava Jean asks, what about being able to show current degree of normality? I don't know exactly what that means, but my thought is, is there any, sort of thinking about, what constitutes different stages of dementia? Do you have any thoughts in terms of like how to, early, moderate, severe?
Right. Okay. So that's like a really, really fascinating question that a lot of us are spending time on. So when I think of Alzheimer's disease, I actually think in two completely, I won't say they're separate, they're related, but two categories. One is the pathology, what's going on in their brain, what are the protein abnormalities, what are the inflammation? And then the other thing is how much memory impairment, how much language impairment, how functionally impaired is someone. So you have the disease pathology, and then you have the dementia syndrome. And those are related, but not but very imperfectly. And so maybe what you're talking about with normality is what we sometimes call resilience or reserve or resistance even. There are people, 5% maybe, of people who, if they die and you examine their brain at autopsy, you can find that their brain was filled with amyloid plaques and tau tangles, but they did not have dementia, and they didn't even have mild cognitive impairment. Those people, for whatever reason we don't understand, they developed the amyloid plaques and tangles, but they didn't develop the degeneration. They didn't lose the brain connections. They didn't have the inflammation that other people with plaques and tangles in their brain and dementia have. We don't understand it, but it's really important that we do understand that. It just shows how complicated this can be. You know, conversely, there are some people, probably fewer, where they have dementia, and you look at their brain tissue after they die, and you see nothing. Their brain looks completely normal. They don't have plaques, they don't have tangles, they don't have Lewy bodies, they don't have TDP-43, they don't have strokes, they don't have mini strokes, you can't find anything. What's happening with those people? Those people are frail. Their brain is just, I don't know what. So these are the extremes. These are the outliers. But I think that we need to understand these extremes, particularly the normal people, the resilient people, the people that have Alzheimer's disease but don't have dementia. What is it about them that we can learn that can help our lives?
It just goes to show that we still have so much that we have to learn about this disease, even after the decades of research. There are a couple of questions relating to research studies. Are there any studies that are currently ongoing now, and how does one get involved in research?
So we do our Alzheimer's Center at Mass General, and also at the Brigham has a number of clinical trials that are going on, everything from nutritional supplements to anti-tau antibodies and infusions and powerful anti-inflammatory medicines, vaccines. I don't know, Chris, if you can kind of post our kind of contact info. I don't actually have it here.
I don't have it on there, but I'm sure we can disseminate it through the mailing list.
Yeah.
So yeah, we'll send that information out for people that are interested.
Right. There are a variety, there are a variety of things. Some of them are oriented more towards prevention of Alzheimer's disease. Others are for people even with moderate stages of dementia, who do need help with kind of daily functioning. We do have a new study that may actually improve symptoms in those people. Another thing that we're trying to get together is really a personalized medicine research platform, so that we can, and this is our goal, and we actually have a fundraising campaign for this, to create a platform where a person would come in and we would actually we would do some blood tests or a spinal fluid test, an MRI scan, and figure out, okay, you have some vascular disease and you've got pre-diabetes and there's amyloid there. So we're going to hit all three of these with, this diabetes medicine and that, blood pressure medicine or things like that. We want to be able to do a personal design of a combination of what's right for the person, and be able to follow them over time with these blood tests to actually see if the medicine helped them, not helped 1,000 people, but helped the individual person. That, I think, is where we have to be.
All right. Next question is, Julie asks, any thoughts on the Brensden protocol? I don't know if you know what that is.
Yeah, so the Bredesen protocol is a kind of intensive nutritional and lifestyle and medical intervention, kind of like what I was describing. I mean, you go, you get a huge, it is a form of personalized medicine with an intensive lifestyle evaluation involving diet, exercise, yoga, stress, a lot of nutraceuticals, turmeric and, curcumin and all a lot of these things. I like it in theory. In practice, I just don't know, because, like I said, the follow-ups on people, you've got 16 case reports, or it worked at, my individual program worked in one person or another, and the scientific rigor with which Bredesen is making that statement is not there, and that's why it's not well accepted in the field yet. So in theory, I like it. In practice, I just don't know.
It sounds like there's not a whole lot of data out there on it, at least as of yet. So, all right. So Leanne is the next one, and Leanne asks, what are your thoughts on the role of social engagement or social interaction and potentially slowing down the progression of MCI?
Critically important. And I'll tell you two things. One, we talk about the importance of exercise and diet and, mental stimulation. There's nothing more stimulating to the brain than interacting with other people. The reading someone's face, listening to their words, thinking the new ideas that someone may present to you. There's nothing more stimulating to the brain than interacting with other people. So it's really important, and we do see it. People get old, they start to have memory problems, and then they're embarrassed to go out, so they tend to stay home, and it becomes a vicious cycle downhill. This has to be addressed. It's an incredibly important component of someone's treatment for MCI. So we have a new faculty member here, Hiroko Dodge, who joined us from University of Oregon recently. She's a senior level professor of biostatistics, but she put together a program called iConnect, where she would, during COVID, she recruited people with mild cognitive impairment who reported being socially isolated, and she had had a number of research assistants just have a Zoom conversation 3 or 4 times a week about various topics. What were your best vacations? What do you think about this current news event or not? Just like 20 minutes of conversation with people 3 to 4 times a week. Of these people who self-reported feeling alone. The results are stronger than anything that I've seen with my MCI in terms of the maintenance or even improvement in cognitive test scores. This study is going to continue, but to me, it's like, what? It's like, it makes sense. We're always looking for the magic pill, but You know, it may be other things. There is disease going on. There is biology. We need to address that. But the interventions that we have, that we already have and know, that aren't magic pills, also have a power that we just don't recognize, or we haven't been able to really prove, really, or avail ourselves.
Yeah. I just want to say also, it's interesting recently, talking with, patients and families, whenever we get the question of, what, support groups are out there, and the Alzheimer's Association and then our program itself, there's a lot of resources when it comes to caregivers for sure. But one area I think that, may be lacking and potentially an area of expansion is, early onset support groups, to kind of facilitate that sort of, social connection. It's something that is severely lacking that's out there, unfortunately, but hopefully that's something that can be addressed in the near future. We are coming up on time. I believe Monique.
I do see that Monique put our website. That's good. Thank you.
Okay, so that's the correct website, www.actru.org. Great. Awesome. Okay. So just to kind of wrap things up, just some of the comments. Thank you to the facilitators and speakers. As I come to see how complex, and maybe I don't have this right, but it seems to me slippery the facts about these diseases are, I am all more grateful to all of you who are working to make life better for your patients. So thank you, Maria, for that. Many thanks to Dr. Arnold. Is encouraged to know that you are on it. So thank you for that. And thank you, Dr. Arnold, for this fascinating information. I learned so much from you. So many thanks to Dr. Arnold. Thank you for joining us tonight and for your wonderful presentation and wonderful discussion. Just to wrap things up, this seminar will be made available on our website. So in the next week or so, if you go to dementiacarecollaborative.org, our discussion will be up there for anyone to enjoy or to replay. So thank you everyone so much for joining us tonight. I hope you all learned something. And again, many thanks, Dr. Arnold, for joining us. And I hope everyone has a wonderful evening. Thank you all.
Thanks, everyone.